Hey, Paul, if you're ever feeling depressed, try drinking a gallon of water before you go to bed.
Why would I do that, Matthew?
Well, it'll really give you a reason to get out of bed in the morning, Paul.
Great stuff. This one's just for me that I found. But Matt, no one likes my kidney jokes.
Okay.
Do you know why that is?
Why?
It's because they're awful. So the joke here is that awful is a term for organ meat. That one's for the foodies out there. Enjoy.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Kashlak Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Franquato, here with my great friend and America's primary care physician, maybe even the primary care physician, Dr. Paul Nelson Williams.
And as always, I'll say, primary care physician. And hey, Matt, how are you?
I'm doing well because we have returning guests for his maybe 25th time, Dr. Joef Topf.
It's like solid gold smoking jacket time now.
Talking about blood pressure management and chronic kidney disease. Our patient gets sicker and sicker throughout the episode. We talk about, management in CKD4, blood pressure management when the patient's on dialysis. We also talk about how does diabetes factor into that and, our goals in diabetes management as patients progress through CKD. Very useful and practical episode. And of course, it's Dr. Topf, so it's gonna be entertaining to listen to. Paul, before I read Dr. Topf's bio, can you please tell me what is it that we do on the Curbsiders? Just remind the audience.
I was a little scared we were going to blow right past it, and I think we would have some confused listeners. But just as a reminder, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. As you alluded, our expert interview is with Dr. Joef Topf today. So Matt, why don't you remind our audience who we're talking to?
Okay, so Dr. Joef Topf, he went to medical school at Wayne State University School of Medicine and did med-peds at Indiana University, after which he did an adult fellowship in nephrology at the University of Chicago. He is currently a clinical assistant professor of medicine at Oakland University William Beaumont School of Medicine. Joel's passion is using social media and new media to teach nephrology. He is the co-creator of Neph Madness, NephJC, and the Nephrology Social Media Collective internship. He created and hosts 2 nephrology podcasts, Freely Filtered and Channel Your Enthusiasm. In 2017, the American Society of Nephrology awarded him the Robert G. Narons Award for Innovations in Teaching. And as always, we are delighted to welcome back Dr. Joef Topf. Before we get to the episode, a reminder that this and most episodes are available for CME for all health professionals through VCU Health at curbsiders.vcuhealth.org. And if you haven't signed up yet, join our Patreon at patreon.com/curbsiders, where you can get twice monthly bonus episodes, ad-free episodes, access to our Kashlak vault with all our show notes and figures we've ever made, and a whole bunch of other cool stuff. That's patreon.com/curbsiders. Joel, you're back on the show. It's got to be close to 20 times now, and maybe some people haven't heard you because it's been a while, so they want to know a hobby or interest that you have outside of medicine.
So I'm a runner. I've been a runner my whole life, but I have recently rededicated myself to that. So in 2023, I ran 475 miles in the year, and I said, you know what, I'm going to run 2 miles a day for 2024. And I am on track. I am currently at 3. I did 3 miles today, and I'm at 378 with 15 days or so left in June. So I'm ahead of schedule. Feels good. I'm really enjoying that.
So average 2 miles a day, or you're not taking any days off?
Average 2 miles a day.
At least 2 miles every day. That's good.
It has to be
That's
14
good.
miles a week. Yep. 56 miles a month.
Okay. I hope the joints are holding up with this. I imagine do you feel good doing this?
Yeah, it does. It feels great. I'm real happy with it. I would highly recommend, physical activity for everybody. It's the fountain of youth.
Paul, anything you'd like to ask?
No, yeah, I'm not sure about Fountain of Youth. It keeps me from murdering people is the reason that I run. But it's always nice to revisit the old favorites, Joel. So why don't you tell us about a favorite failure and perhaps what you learned from it?
So, an important failure that taught me a lesson was I was working with a new curriculum, and there was a number of different teachers. And one of the other faculty members was a junior faculty, and I didn't think they did a great job on one of their lectures. And I thought, I should reach out. That I've been doing this for a while. Let me reach out and see if I can help them and kind of mentor them up and try to help them do a better job. And all they heard was, Dr. Topf thinks I did a crappy job with my lecture. And they went to the course director, and I got a talking to, and as long as these no good deeds goes unpunished. And but it did kind of make me think. It's like, you know what? Mentees need to request a mentor. It has to come from the bottom up. I don't think it can come from the top down. And so I have changed I no longer do that. I'm happy to help people that are looking for help, but if people are not seeking it, I don't reach out.
Yeah, that's tricky. I mean, so I wonder if if the course director would have given them the feedback, if they would have been more receptive, because that was someone they saw as in a position that was like maybe going to be giving them feedback. Who knows?
Yeah, I mean, I didn't want to embarrass them. I didn't want to talk to somebody else and say, this person's not doing a great job. I clearly was a little ham-fisted the way I went about it. I thought they would be receptive, and that was just not how it was taken. And, I wasn't trying to make them feel bad. I was trying to do something that was nice, but did not get received that way.
I wonder if this will be one of those things where they'll thank you in the future because you had the guts to correct them.
I was going to say the same thing. Yeah, I don't know. I think, especially since they're junior faculty, at that point, like, you're so terrified someone's going to call you out or think you're an imposter, you're not doing a good job. And then you get to mid-career, sort of where we're at in our careers, and just, I don't know about you all, but I live in mostly a feedback-free zone. Like, every so often I get, nice job, and you're like, okay, I'm not really sure what to do with that. Like, and I still would like to do better, but you're not getting any kind of specific feedback. So I agree, Matt. I think probably in time they'll wish they got a little bit more concrete feedback than what they're getting. I think it's just maybe the stage of career that they were in when you talk to them.
Well, speaking of feedback or advice, Joel, do you have any feedback or advice you want to share with the audience?
I was in a patient's room once, and there was an old cowboy movie showing on television, and one of the characters was injured, and they were in a cave, and they found a Native American medicine man to provide medicine, and he does all this stuff, and there's herbs involved, and there's smoke, and the compatriots go, he's going to work. Is he going to work? And the medicine man looks at him and says, sometimes the medicine works, and sometimes the medicine doesn't work. And I just like, man, if that's not my life, right? I can do all this crazy stuff, right? And patients have no idea what I'm doing and whether it makes sense or not. And there's a lot of ritual involved. And in the end, sometimes it works and sometimes it doesn't work. And so we're right there with them.
Yeah. I don't know how many times it's not just the medicine working, it's just the plan working. Like I see somebody and it's been like 3 months and I'm like, how did it go with that medication? We talked about all this stuff and they're like, oh yeah, I never got it. And I'm like, like I went to the pharmacy once, they said there was an issue with the order. I'm like, so you didn't tell me? Like, no, I had no idea. So you waited 3 months. So now we lost 3 months of time. That happens so often.
Yeah. And it's almost always when I feel really smug or proud of myself, like a kind of medication, I feel like it's going to fix 3 things at the same time. I'm like, all right, at least one of these things has to get better. Like, no, I took it for 2 days. I didn't like it. And you're like, oh, all right. It's just, yeah, it's very deflating.
Yes. That's medicine for you. But Paul, let's see if we can fix a fake patient from a hospital that's real in our hearts, Kashlak Memorial.
Sure. Joel, we're going to tell you about the sad case, or maybe a happy case, I don't know, we haven't gone through it yet, of Mr. A. This is a 58-year-old gentleman. He's got a history of CKD, hypertension, type 2 diabetes. Over the past 6 months, he's had persistently elevated blood pressure readings in the office, averaging about 160 to 100 millimeters, 160 over 100 millimeters of mercury, despite being on the maximally tolerated doses of losartan, our favorite, carvedilol, and hydrochlorothiazide. He reports no new symptoms, so he's not in hypertensive emergency in the office, apparently, so no headaches or chest pain or shortness of breath. Blood pressure, however, remains persistently elevated. You've done your secondary workup, so we've done our due diligence. We listened to the episodes. We checked renin aldosterone. That was fine. We ruled out a theo. We even did a renal ultrasound, hoping maybe we'd see some sort of stenosis or something that we could deal with. But no. So we're worried about how to manage this patient's blood pressure while still making sure that we're hanging on to the kidneys because the GFR is 28, and we're worried about actually causing more harm than good by trying to be more aggressive and adding more agents. So I guess before we get started as to what medications you would consider or what you think about this case in general, could you just sort of talk us through where in the kidney's lifespan this person is and how you would sort of classify them?
Right. So, kind of the first thing was like, how are we going to classify this person? And I think, the important thing about, recognizing about chronic kidney disease is that it is not just a GFR. Like, I think we under-recognize how important the albuminuria is. And so there's no mention of albuminuria here. We know that they have a GFR of 28. I'm assuming that's a creatinine-based GFR. But, so we try to classify etiology. What's the cause of this? Is this diabetic or hypertensive or some other glomerulonephritis? Doesn't look like we know that he's got diabetes. We know he has hypertension. If there was a lot of proteinuria and there was like a long history of that and had some other end organ damage from the diabetes, you start to build a case that this is diabetic kidney disease. So that would be the etiology. We know the GFR is 28. And then the next step would be the albuminuria. And that's super important for kind of getting a sense of what the trajectory is going to be. Is that I'm a big fan of the kidney failure risk equation that allows you to put in age, gender, GFR, albuminuria, and get a 2-year and 5-year renal prognosis for the patient.
Is that the heat map?
So here's the thing: the heat map gives you a relative risk to a low risk patient with a good GFR and a normal creatinine. It just says, if it's red, it's 4 times that risk of progression. But since you don't kind of know what the baseline risk is that, buying 4 tickets to the lotto increases your rate of winning the lotto by 4-fold, but you're still not going to win, right? Because the baseline risk is so low. So the relative risk, I don't think, is super helpful when the risk is low. And the kidney failure risk equation, kind of the same idea, but instead of giving you, this patient is high risk, it says there's a 5% chance that this patient is going to be on dialysis in 2 years and a 15% chance in 5 years. And all of a sudden, like, people get that. They can start to understand. They're like, it's not going to happen, but 5% is a real risk. And though, it is helpful to communicate to patients. I think patients are much more receptive to that than just saying, you're at high risk. I think they kind of hear high risk about all kinds of things all the time, and they have a hard time incorporating, what does that mean? But a percentage really works for that. But with this case, we're missing that albuminuria. Do we want to throw that out there?
Yeah. I mean, maybe let's say it's like 75. And I actually went to kidneyfailurerisk.com, put in the age, 58-year-old male, North America, GFR 28, and urine albumin to creatinine 75 milligrams per gram. And if I put that in, it's asking me for some other information.
Skip that.
To make it like corrected calcium bicarb albumin phos. But I'm going to skip that. And it says at 2 years, the risk is 6%. At 5 years, the risk is 17.87%. And this would be considered stage 4 kidney disease right now.
Yeah. Increase that proteinuria to 750.
Okay. So if we put in 750 instead of 75, at 2 years, the risk goes to 16.32%. And at 5 years, the risk goes to 42.66%.
Yeah. And so, you're talking roughly half at 5 years. And then, for me, at 26%, once they cross 20% at 2 years, I start really talking about dialysis modality. That's when I kind of initiate the conversation. When it's 20% at 2 years, people get that. They're like, it's not likely that it's going to happen in 2 years. It's possible, but this is enough of a risk that I'd carry an umbrella. That he said it was a 20% chance of rain. Why don't we talk about what our dialysis plans are? And then when it's 40% at 2 years, then we start putting the access in. Right, time to start Joel, build that fistula.
We did a kidney transplant episode, and I believe it was we were just saying that some patients are not being referred soon enough, and so this is helpful to have these numbers that we can start thinking about this. Certainly, generally, anybody that is CKD4, I refer to a nephrologist. I'm not sure about you, Paul, but that's kind of my threshold.
CKD4 or significant albuminuria with CKD3, or actually significant albuminuria really at any stage does make me nervous enough if I don't have a good reason. Even if I do have a good reason for it, they're going to see the kidney doctor.
So it's interesting, just a couple of months ago, the 2024 KDIGO chronic kidney disease guidelines were updated. And this is the first update since 2012. And one of the new things is they've incorporated these risk equations, and they're using these percentages to do things like refer. So they say that if they have a 3 to 5% 5-year risk of dialysis, they should get referred, kind of regardless of where their GFR is. And I love that because, kind of using this GFR without looking at proteinuria, it doesn't, I get these little old ladies that are 80 years old and they got a GFR of 48 and they got 12, milligrams per gram of albuminuria. They're not going anywhere. That creatinine is going to be probably stable. They're never going to progress, even though they've got CKD stage 3B or what have you. I don't need to see them. Okay, and I'm happy to see anybody, but I think they come in terrified that they're going to need dialysis, and I just get to be the hero and say, no, you're never going to need dialysis.
Joe, on that point, this was brought up at ACP this year. The older adult, like 65 plus with CKD3, and their EGFR is in the 40.
The 3A question.
Yeah, like, do we order a cystatin C to try to recategorize those people? Can you talk us through that?
Yeah, so that's the other thing that's part of these new guidelines is that it's kind of cystatin C's prime time. I mean, you think about the history of cardiology. We've gone from LDH to CK to CKMB to troponin to troponin I to troponin high sensitivity troponin. Like, we keep getting better and better markers of heart disease, and all that time it's been creatinine. There's been no developments, but cystatin C is a meaningful change. Like, think about how we've tied ourselves in knots over these GFR equations in race, and just get rid of creatinine. You don't have to worry about race at all. I love looking at the cystatin C equations because some of them because they're old equations, the calculators were built off of creatinine base. They'll allow you to put race in. You flip the race back and forth. It doesn't do anything to the GFR. It's not related. I love it, right? What a better solution than tying ourselves in knots with these equations, which is what we've done. I'm delighted that we've gotten race out of the equation. I want to be very clear about that. The 2021 equations are all that I use. But even better is get something, and it's just not a race issue. It also gets around a lot of problems with gender, which is not nearly as binary as it once was or was in a lot of textbooks. And that's a thing that's a big problem. But because cystatin C is not dependent on muscle mass, completely get you out of there. You don't have to worry about amputations. You don't have to worry about bodybuilders. You don't have to worry about people of particularly small stature. You get out of all of those problems. It's not perfect. There are other things that it's affected by inflammation. So the cystatin C level will rise and somebody who's got a lot of inflammation. I talk to people that work in ICUs and they have patients with tremendous sepsis and they're like, cystatin C not so helpful there. But in my hands, when I see it, I just find it to be way more reliable than creatinine. And so I love that. And in the large epidemiologic studies, it is a better predictor of the outcomes that we care about. Death, cardiac disease, hospitalization, kidney failure, than the creatinine-based GFRs.
Joel, so what I've started to do for my patients with CKD3A or people that are worried about their CKD, I've been ordering a cystatin C as well, just to see if I can recategorize them, to see if I need to be more or less worried about people. Is that the right way to be using this?
Yeah, I'm just about all of my new patients, when I see them, I'll get a cystatin C right off the bat, see if there's any discrepancy. Most of the time, it correlates nicely with the creatinine. And one of the easy things about it is that the normal cystatin C is roughly the same as the normal creatinine. So if you're used to saying, creatinine of 1 is roughly good and 1.5 is starting to get iffy, you really can just straight correlate that directly with the cystatin C. You'll know how to interpret it. Just think of it as a creatinine. It makes it very easy to roll into your practice. You don't need to learn new numbers. And so I will do that on a new patient. Let's see if this changes their categorization. And there's a particular people where I find it repeatedly useful. So one, young people that are healthy but are very athletic and very fit, oftentimes they'll have an elevated creatinine. Oftentimes they're supplementing with creatine, which is bumping up their creatinine even further. And you get a cystatin C and you get out of that box easily. I love that. Patients are super happy to be told they're healthy because that's how they felt. They didn't feel like they had a disease. They couldn't believe that they were going to see a kidney specialist. You say, hey, this is the reason it's a problem. This test avoids that problem. And then I actually have a number of elderly patients that have, they're very fit and they're more muscular than is average for a 60-year-old woman, right? And they're going to have a creatinine that's, it only takes 0.2 or 0.3 to be high enough to kick them from GFR of 65 to a GFR of 48. And that's enough for them to get categorized as CKD3. They get freaked out. They're like, oh, there's only 5. I'm halfway to dialysis is what they say. They look at, it goes 1 through 5. And I think it's a pretty significant problem with the way that they've staged kidney disease. I think it causes a lot of unnecessary concern. But cystatin C is nice if you can get those patients to get recategorized. I like that.
Paul, you think we should talk some blood pressure now?
Yeah, well, let's say we're even bold. And for Mr. A, we check the cystatin C and it actually correlates well, and we're still fairly convinced his GFR is sitting where his GFR is. Which, as a reminder, since we've been talking for a little bit, is 28. This is a patient who's hypertensive on, I believe, amyl hydrochlorothiazide, losartan, and carvedilol at the maximally tolerated doses. So where, Joel, would you go from here with this patient? Is this someone that we should maybe pull the trigger on with like a spironolactone? No one likes hydralazine. No one likes it except for the occasional surgeon for as a PRN medication. But otherwise, no one likes hydralazine. But what would you add on to this patient? What is next for them if you're concerned that you don't want to change their renal function for the worse while you're trying to control their blood pressure for the better?
Yeah, I think trying to be real focused on the GFR at the expense of blood pressure is just kind of missing the forest for the trees. That the goal here is to get that blood pressure under control. If we have to sacrifice a couple of points of GFR, that's fine, right? We don't want to over-index on that GFR. That's not a patient-oriented outcome. I know, and you need it. It's tough to explain to some patients as they look at their labs and they start to focus and perseverate on that. But I think that's one of our jobs to say, hey, this thing goes up and down. It's a biological variable. We're going to focus on what we really need to do. We know we have tons of data showing that if we can get that blood pressure under control, it's going to be good for your heart. It's going to prevent that stroke. It's going to prevent dementia. You can prevent erectile dysfunction. There's so many advantages to getting that blood pressure under control. Let's really focus on that. And so the first thing I'm going to be doing is I'm going to be switching out that hydrochlorothiazide for chlorthalidone. And I have less confidence in it than I used to because there was a big trial last year. Did you guys cover the diuretic comparison project where they randomized patients that were on hydrochlorothiazide to switch over to chlorthalidone, and it was a big nothing. They didn't find any changes in any kind of outcomes. But I think that there's something about that trial that I think they were using equivalent doses of chlorthalidone in hydrochlorothiazide. So that meant that if they were on 25 of hydrochlorothiazide, they got 12.5 of chlorthalidone. Well, that's never what I do. I do a milligram for milligram. So I essentially effectively double their dose. I go from, if they were taking 25 of hydrochlorothiazide, which is generally what internists do and limit there, I just go to 25 of chlorthalidone, which is a sneaky way to double their dose. And I dose it every day of the week. And so that dose will start to accumulate. And I do see improved blood pressure control with that change. So that would be the first thing that I would do. Kind of along that same lines is losartan, not a great once daily ARB. It has a half-life 2 or 3 hours. And so I would switch it to a longer acting ARB. I'm a fan of telmisartan in that situation. And then patients not on a calcium channel blocker. And so that would, again, I wouldn't do all of this at the same visit. I would kind of stepwise through this, but I would add a calcium channel blocker. I think in my hands, nifedipine seems to be more effective. I get more good variability in dosing between 30, 60, and 90. And so I would do nifedipine long acting as an additional drug on top of that.
Joel, so to recap, you would give the patient chlorthalidone instead of hydrochlorothiazide. Losartan's a short-acting ARB, so you would give them telmisartan or something else that's longer-acting. And then you would potentially add a calcium channel blocker like nifedipine. I was going to ask about indapamide, which is another longer-acting diuretic. I've started to use it a little bit because it comes in a 1.25 and a 2.5 milligram dose, so it's a little easier to step up than chlorthalidone, which comes in a 25. And we've
And that's
talked
it.
about in the past, like, do we
Yeah.
dose it every other day or do we dose it daily? Because chlorthalidone's a pretty big gun and can lower people's potassium and magnesium.
Yeah, I mean, we're 160 over 100. We're far away from where we need to be with this guy. I think I'm not too worried about it, but you're right. It is a little bit difficult to dose. And then I don't know if you've seen the pill. It's really crumbly. Like it's hard to even cut it in half. And all of a sudden you got like chlorthalidone dust. It's a tough one.
Yeah. So indapamide, are you a fan or not?
Yeah, that's fine. The reason I love clothalidone is we have that study, the CLIck study by Agrawal, which showed that in patients like this, in patients with CKD stage 4, they got really effective blood pressure control, and that it kind of stands alone. We just don't have data for other blood pressure medications in these advanced CKD patients, and so that's one reason that I reach for clothalidone. But I think your reasoning and logic is tight.
And limiting factors here, like we've talked about hyperkalemia in the past. So for some patients with CKD4, you do start to run into that issue with hyperkalemia. So is 5 your threshold? I think we've talked about, Dr. Cohen said sometimes she'll let it go up to 5.5 in some people if they've been stable and they're on an ARB. She'll let it ride at 5.5 or less. But what's your comfort level? Do you like to be more like 5 or less?
I'll go into the low fives. I think 5.4 would be that's the upper limit of normal for our lab. And so if there's no H next to it, I'm good with it. Right.
Yeah.
It's not very sophisticated, but yeah, the low fives is where I'll go. I see oftentimes people cross that GFR of 30 and people start peeling off the ACE inhibitors and the angiotensin receptor blockers. And I just really think that's misguided, right? Like these are drugs that have been proven to reduce outcomes. They're great for heart failure. They're great for stroke. They're great for diabetic kidney disease. It prevents the outcomes that we're trying to prevent. And this is what we should be doing for our patients. And we actually even have, there was a randomized controlled trial called Stop ACE, where patients were, as their GFR fell below 30, they were randomized to hold the ACE inhibitor or continue it. And they did just fine if you continued the ACE inhibitor. It didn't accelerate their time to dialysis. And there's been a number of really sophisticated retrospective reviews that have looked at that same question and very consistent finding. And they actually found that when you stop the ACE inhibitor, those patients ran into cardiac events more often. And so that's why we treat the blood pressure to prevent these cardiac events. So don't remove your best weapon for that. We can then work around the other problems. The hyperkalemia is the one that people worry about. And we got, you can use diuretics for that. You can use potassium binders. Those are all kind of acceptable techniques now to be able to continue these drugs.
Yeah, I mean, the binders, one of the things I worry about, I find that they've been pretty safe. I don't know that I've seen many adverse events from them. I think it's more the cost has been the issue for some patients, putting them on like just so they can continue their ACE inhibitor, or an ARB, which are generic and cheap meds. They have to spend like a couple $100s a month on a binder. Are you running into that issue too?
Yeah, it makes me nervous. I've had the patient, that they, you see them in the hospital and they're like, "Doc, I ran out of my binder, but don't worry, I didn't stop my ACE inhibitor. I kept it going." And I'm like, they're like, "I know I ran out of one medicine, but I'm going to stay on my other ones," because they're so focused on you. They know
Right.
that you want to keep on the medicine, but you're like,
Yeah.
it's tough to pair those two together. I guess what I would say is that I was pretty skeptical of these binders when they first came out. And I thought, oh, I can control the potassium other ways. Honestly, they're really effective at controlling that hyperkalemia way better than, at least in my hands, the diuretics have been. I've been delighted with how well they work.
Yeah. And we never got the outcomes data, right? Wasn't there some trial that they were trying to look at the outcomes if they like being able to continue the ACE or ARB? Is that still the case?
Yeah, so I think that was called the Diamond trial, and it kind of got flummoxed by COVID. And so what the data that we have is that these drugs allow people to stay on their mineral corticoid receptor antagonists. It allows them to stay on their ACE inhibitors or their RAS inhibition. But the next piece of data is show me that staying on those drugs reduces outcomes, and that has not been done. And so we're missing that piece, and it's kind of a leap of faith. It's not a leap that I'm comfortable making that leap, but it is a gap in the evidence for sure.
Okay, Paul, you want to go back to the case and we can make Mr. A little sicker?
Yeah, I love making patients sicker. It's why I got into this business. So let's say we follow Dr. Topf's excellent recommendations. So on chlorothalonil now, we have one on ARB that we like a little bit better. So the blood pressure has been better controlled. So we pat ourselves in the back. Some time passes, and Mr. A is diagnosed with CAD in the form of an MI, has undergone CABG, and it now has class 2 ACHF and is on the eplerenone. Let's leave them on the telmisartan, carvedilol, and chlorothalidone. GFR now 26, and A1C is 6.8%. So the patient's, I guess, phenotype has changed a little bit. Now we have heart failure into the mix of this patient with chronic kidney disease and type 2 diabetes. So talk us through sort of how we should think about this patient, what the evidence is for sort of tweaking or adjusting the medications. I know it's a broad question, but I'm sure that you have thoughts about this regimen.
Yeah, I mean, we're looking for guideline-directed medical therapy for his heart failure. This is a well-worn path. We're all familiar with the agents that are used here. The problem is, for all of these studies, patients with GFRs less than 30 were excluded from the trial. And so, this guy just falls into an area where we don't really have evidence here. But I don't see anything in these patients that tells me that their physiology is different, that their heart failure is different, that they wouldn't respond to the same therapies. And so for myself, I'm happy to make that leap of faith. And for some of them, I think they're easy. So he had strong indications for SGLT2 inhibitor in this situation. These are drugs that are going to be good for preventing his renal outcomes, and it's going to be good for preventing his heart failure outcomes. So, and improved mortality. So a clean win. The EMPA kidney trial is the lowest GFR that we've gone. That brought those patients were initiated on the drug down to a GFR of 20. And that's when they were starting the drug. And one of the interesting things about that trial is if those patients ended up on dialysis, and more people on the placebo than on the study drug ended up on dialysis, but some people on the study drug ended up on dialysis, that was not an indication to stop the drug. And so they stayed on study drug even though they were on dialysis. And then somebody afterwards went back and looked at well, how did the patients on dialysis do? And the ones that are on SGLT2 inhibitors or EMPA and dapagliflozin in that situation had better outcomes than their matched controls that were on placebo, even on dialysis, which kind of blows my mind. For a drug that's supposed to work in the kidneys, I don't know why it works when they're still on dialysis, but whatever. I mean, the evidence is the evidence, and that's the best we've had. We're running a trial right now called the Lifestyle Trial, and they're actually going to randomize patients on dialysis to dapagliflozin or placebo. And so we're gonna get a good trial dedicated to that question, and it kind of just shows how remarkable these medications are. Really, really powerful medications. Thing to remember is, I know these were introduced as anti-hyperglycemic agents, but once their GFR falls below 40, you're not going to see an improvement in their A1C. It's just not. They just don't have enough glucoseuria or glucose being filtered to make a difference there, but they still get all the other advantages in terms of heart failure and kidney failure, but you're not going to see improvements in diabetes.
And it looks like the worse their albuminuria, the more benefit they derive from SGLT2 inhibitors from what I've seen as well.
Yeah, I think you need to be careful there, is that it may be a trick of the studies because those patients have a lot more outcomes. And so you're going to be able to see you're going to get a bigger benefit because they're more risk.
Right.
And these studies are always short, and the study's been so impressive, we've been stopping them early, further penalizing these more subtle benefits. Mm-hmm. And so the most extreme of those is that in the EMPA kidney study, they actually enrolled patients with no proteinuria at all. And if you look at the primary outcome, there was no difference. But if you look at the secondary outcome, which was the slope of GFR, it did slow the progression of kidney disease by the slope, which is actually it's a continuous variable, so it's easier to show a difference rather than the dichotomous variable. If they started dialysis or they didn't, or they had a 40% drop in GFR, where they had very, very few events. And so my sense is they work kind of across the span of kidney disease, but it's going to take longer and it's going to be more subtle in patients that are less sick.
Mm-hmm.
I'm not sure what it's looking like for you, Matt, but I can tell you that what I've seen an evolution. Once upon a time, everyone was waiting for everybody else to start the SGLT2 inhibitors for a patient like this. So cardiology would defer to endocrinology, who would defer to nephrology, who would defer to primary care, and then the patient would just not end up on this life-saving medication. But now I feel like the person who thinks of it first is often the one now who's sort of pulling the trigger on it. Everyone else seems kind of okay with it, which seems like a positive thing.
Yeah. I mean, it's often the primary care now, in at least where I practice, that's pulling the trigger on it. But yeah, I think it's great that there's multiple specialists. Like, the nephrologist or the cardiologist might start it if the internist doesn't think to do it, which is great.
Now, I'm thinking more like acute hospitalizations for cardiac events, like patients prior to discharge are sort of getting started on these medications, sort of irrespective of what their kidney function is, which is kind of God bless and congratulations for being bold. So it's just it's people have a lot more comfort with them than they used to, which is nice.
Yeah,
I think the comfort comes from as we get experience with these drugs, they're really innocuous. Patients tolerate them fine. They don't. I mean, it's an easy drug to prescribe, and you start doing it. You're like, I'm not getting any blowback from my patients.
Yeah. Once in a while, you get the hospitalized patient with euglycemic DKA. I have to say, I have seen that, but that's something to look out for. But it's not like, compared to the number of people on these, I'm not seeing it all the time.
Yeah.
We haven't covered the mineral corticoreceptor antagonist, which I think is it deserves a bit. So we talked about RAS inhibition, that we have good randomized data that need to be maintained on it. This is something you should be doing. I'm going to extend that to the ARNIs, that those drugs work and they're effective in these patients with low CKD or with low GFRs, though they were excluded from all the pivotal trials, unfortunately. But I'm using them. I'm seeing them being used. Again, I even have patients on dialysis that are getting these ARNIs, and besides some hypotension, they seem to be well tolerated. And there's some data that they have less hyperkalemia compared to patients that are just on ACE inhibition or RAS inhibition. So I like that also. But the one that is problematic, I think, is the mineralocorticoreceptor antagonists, the eplerenone, the Spiro. I definitely use them in my patients with CKD stage 4 and 5, but I am very nervous about it, and my frequency of hyperkalemia is very high. So you just need, I'm always taking a look at where the potassium is when I started. I'm making sure I follow up with that, talking to the patients about this, because it's the worst thing to do is to call that patient at 8 o'clock or 9 o'clock at night and say, got to go to the ER. I hate doing that. And really, and I've had it with these are the drugs that do it to me the most.
And finerenone, it looks like from the trials, finerenone doesn't lower blood pressure as much. We're mostly using that for diabetes, CKD, and diabetes with proteinuria. It seemed like the potassium was a problem with those just as much as it is with spironolactone and eplerenone.
So I want to be careful here. So finerenone does not have an indication for heart failure. They have an indication for people with increased cardiovascular risk, which sounds similar, but it's not part of that guideline-directed medical therapy for heart failure. It's not going to be on that track. You're going to want to be using eplerenone or Spiro for those patients. But otherwise, exactly what you said about finerenone is exactly right. So if you got a patient that's not heart failure, but they have cardiovascular risk, they're a smoker, they got what have you, atherosclerotic heart disease, great drug for that, saves lives, also slows down the progression of diabetic kidney disease. Now, the important thing is in those trials, is it
Fidelio?
Fidelio trial. Figaro was the non-kidney outcome. That was just the heart outcome.
Oh, I'm sorry. Forgive me.
There was a Figaro and a Fidelio. Yeah. They only enrolled patients with a potassium less than 4.8, which is to me, it's wild that somebody would have a normal potassium in the 4s and they'd be like, oh, no, that potassium's too high for us. We're not going to touch them. And it makes me think, hey, and they still had trouble with hyperkalemia, right? They had a lot, they had like 20% of patients having hyperkalemia, and they were throwing diuretics at them and they were throwing potassium binders. It is a real issue with these patients. And so just recognize that this is a problem, be careful about it, counsel your patients that, hey, it's kind of the last thing that I want to add. I want to make sure we got everything else in place and say, okay, this is the last thing that we can do, but there's some risk here.
Yeah. So this, this case we gave you where the patient is on eplerenone, that would be a last resort, and if the potassium was already 5, they're probably not going to tolerate it if you start eplerenone.
Yeah, I wouldn't even start. Yeah, if the potassium's 5, I'm not even starting a pleurodone. Absolutely.
Okay. So to recap what we talked about so far, for CKD4, basically ACEs, ARBs, we can use them. We can use diuretics, probably chlorthalidone or indapamide, the longer-acting ones. If the blood pressure is not controlled with hydrochlorothiazide, we're going to need to use some of those stronger, longer-acting diuretics. And we talked about SGLT2 inhibitors. If these patients have heart failure as well, even if this patient ends up on dialysis, we could still continue the SGLT2 inhibitor. And in the trials, they started them with people as low as an eGFR of 20, you said, right?
Yep, in the EMPA kidney trial.
Yeah. Okay. So I wanted to shift gears slightly before we talk about patients on dialysis. And this patient has an A1C of 6.8%, but let's say it was 6.2% and he's actually taking a sulfonylurea and no longer on metformin, but the patient's excited that this is the best his A1C has been, 6.2%. How do you talk to patients about their diabetes when they have this advanced CKD, and what kind of pitfalls are are there out there that we should be aware of?
Right. I think we're kind of in a transition in diabetes management, that we have sulfonylureas that kind of I think of them as the bad old days, that these are drugs with real risks for hypoglycemia. And I certainly worry when I see that A1C falling in patients with advanced kidney disease, that we may be increasing our risk of hypoglycemia. But, we have these other drugs, these newer drugs, the GLP-1 receptor agonists, the DPP-4 inhibitors. These are amazing drugs, and we don't see this hypoglycemia with these other drugs. So I think it really depends on how you are managing that, about how concerned you're going to be. Now, when the patients are not yet on dialysis, so CKD stage 4, CKD stage 5 not on dialysis, I really love tight glycemic control. I think we've got good data that shows that tight glycemic control reduces the progression of kidney disease. This is what your patient cares about. None of them want to go on dialysis. They're willing to do a lot to avoid dialysis. And so I think you need to partner with your patient and pair with them to help work on that. But you want to get them on the safer drugs. And you want to be careful about that, because that hypoglycemia is really dangerous. All right, you remember that the original diabetes complications and control trials from the early 90s, if you look at the outcomes that they tracked, I mean, they were able to reduce albuminuria by getting tight control. And these were type 1 diabetics, and this is why we adopted tight control for everybody. But if you look at the outcomes that they were following, there wasn't a reduction in mortality, and it took 15 years to get a reduction in mortality. And some of the things that they were tracking auto accidents, which meant that there were patients that were getting hypoglycemia and dying in auto accidents. And they even tracked the death of the passengers, right? Because they were like, that's an outcome that we need to be worried about.
Oh my gosh.
Like, no, yeah. So this is New England Journal of Medicine, like 1992, DCCT trial. This is the trial that we all point to. This is why we do tight control. And you read the results, and you're like, I don't know if the reduction in albuminuria was worth this, right? Now, again, eventually it panned out, right? The endocrinologists were right that if you did this for long enough, and it was like 15 years of follow-up before they were able to show the improvement in mortality. But there was some real cost to doing this. And it's great now that we're having better, safer medications where we don't have to worry about those complications, at least in type 2 diabetics.
Yeah, we've talked about this in the past, that metformin, once the GFR goes below 30, we wouldn't initiate it. Even if they were on it, if their GFR is down in the 20s, we probably stop it in most patients.
Yep.
The GLP-1 agonist, I've started to see some things in the literature where maybe those also have some kidney protection. I know SGLT2 inhibitors is pretty clear that they're good for the kidneys. They can prevent progression. Are you as convinced with the GLP-1 agonist that they do anything for the kidneys?
Yes. So we just had the first definitive trial came out last month. It's called FLOW, and it was semaglutide 1 milligram weekly, which is actually a relatively low dose. I'm seeing a lot of a lot of patients are getting 2 milligrams and higher, at least for weight loss and for diabetes. But this was 1 milligram of semaglutide weekly versus placebo, and they had a reduction in the classic outcome of 40% drop in GFR, death or dialysis. So perfect, exactly the kind of same compelling data that we've seen with the SGLT2 inhibitors. Some of the other agents have also been able to show improvements in albuminuria. And so I suspect that I'm not sure I'm willing to go with class effect, but I think it's not going to be semaglutide alone. I think there's going to be other agents that are going to show that same type of effectiveness. But in terms of actually hitting that outcome, semaglutide is the first one. And hopefully we'll see others follow behind that. But that's a big deal trial flow.
Mm-hmm.
All right, Joel. So let's say despite our best efforts and our prognostication, Mr. A ends up on hemodialysis and is doing okay. His blood pressure runs 140s, 150 systolic over 80s to 90s diastolic on 9 dialysis days. But sometimes he has hypotension, or at least relative hypotension during dialysis. And so now that this patient is going through hemodialysis, I wonder if you could sort of talk us through how that impacts how you actually manage their blood pressure. Do we have to do sort of alternate day regimens, or just how do you think about blood pressure in general once someone is on hemodialysis, and how do we make the whole process as painless as possible for them?
Right. So we're seeing these patients 12 times a month when they come to dialysis, 3 days a week, week after week. And when they come in, they get a blood pressure when they start. When they leave, they get it every 5 minutes while they're on blood pressure. I have a pile of blood pressure readings. And one of the really interesting things to come out is that all those in-center blood pressure readings don't predict cardiovascular outcomes. They're just not good at that. We measure them all because they're super important for delivering dialysis. We need to make sure they don't get hypotensive during dialysis. But in terms of patients come in, they're very hypertensive, they just walk in. It's usually early in the morning. Someone's about to put a 14 gauge needle in a fistula. I'm not surprised that their blood pressure is 160 over 100. That's
right.
Understandable. And it's also understandable that that's not going to predict long-term outcomes. I think we're really capturing just kind of this microcosm of what's going on. And then when their blood pressure drops after we've pulled off 3 liters in 3 hours, again, not surprising that it is not something that's predictive for long-term outcomes. And what we're seeing is that in terms of adjusting blood pressure, we want to look at blood pressure on non-dialysis days. And so, ideally, that's ambulatory blood pressure. You put a cuff on them and measure it every 20 minutes when they're at home and every 30 minutes when they're sleeping. But home blood pressure readings are also really good. And that's going to be that's the gold standard. That's what we're looking for, is let's ignore all those readings that we get in the clinic, and let's get either office readings on non-dialysis days or home readings. And that's what we need to use to monitor and guide their blood pressure. That said, it is really difficult for us when patients take a handful of blood pressure medications and then roll into the dialysis unit and get hypotensive. And so the standard advice is we're going to hold those blood pressure medicines on dialysis days until after they're off dialysis, get them covered once their blood pressure recovers. And so, in the end, this is going to be individualized from patient to patient, depending on how they do. But you're going to want to coordinate with the nephrologist on that. But the important signal here is that when you see that patient in your office on a non-dialysis day, you're providing information that the nephrologist doesn't have. We never see the patients on non-dialysis days, and that's the only blood pressure that really counts in terms of reducing this cardiovascular mortality. And so I think it's you're providing really important information, even though I'm drowning in blood pressure readings. None of mine make a difference. And the one that you grab is the one that's going to be able to help that patient.
Joel, I was trying to find an article on managing blood pressure and dialysis, and I couldn't really find anything super recent. I resorted to looking at Up to Date, which just to see what they said, which I always do that for every topic. Look at the literature, also look at Up to Date. Up to Date mentioned atenolol being their first choice blood pressure medicine for patients on dialysis, and I was shocked.
Yes, right. Atenolol is usually the punching bag of blood pressure medications. If you want your blood pressure medication to look good, just compare it to atenolol and you'll do great. And there was a study, we've already talked about Dr. Agarwal because he did the CLICK study, but he also did one of the very few randomized controlled trials of blood pressure treatment in dialysis patients. And it was a very clever trial. Atenolol accumulates in dialysis patients. And so he did directly observed therapy. He would give them 100 milligrams of atenolol when they were in the dialysis unit. And it was atenolol versus lisinopril. And It's an underpowered study. There weren't that many patients in it, but they did get a survival advantage with atenolol. And, our patients die of sudden cardiac death. That's one of the things, the major causes of death in dialysis. And like beta blockers tend to be pretty good for that. Like you can kind of build a framework in your mind to support it. And so, yeah, there's reason that like UpToDate didn't just make that up like that. There's
Yeah.
RCT data on it. I think there's a lot of skepticism because the study was underpowered, but it's an area that's really under-investigated and terribly unfortunate that it is. Like we should
Yeah.
be able to do better for our patients.
So what would you recommend if somebody, I mean, usually I'm not adjusting meds on someone that's on dialysis. I'm not usually adjusting blood pressure meds, but what is your general order of medications that you go to for a patient that's on dialysis that still has high blood pressure?
I'm using a lot of calcium channel blockers. I'm using a lot of ACE inhibitors. I'm using some beta blockers, though usually it's carvedilol rather than atenolol.
Mhm.
Because a lot of these patients have, the frequency of heart failure is through the roof in these patients. And so I
Yeah.
end up trying to stay on guideline directed medical therapy. And then spironolactone, again, another weird one where you wouldn't think it would work. They don't have functioning kidneys. It does work. You get good blood pressure lowering effect from spironolactone. In non-selected patients, you don't just need the patients with high renin-aldo ratios or aldo-renin ratios. But again, strangely enough, it still causes hyperkalemia. We think it's colonic potassium clearance that is inhibited by Spiro in that
it's wild.
situation. Yeah, right. And so, if you have and most patients, once they're on dialysis, their potassium is fine, but there's occasional that we run into a few patients with hyperkalemia. Probably not a good idea for those patients. And then, but also the really important thing, probably the most important thing is if they have pretty high blood pressures, don't just reach for meds. Make an adjustment in the dry weight. Most of these patients have volume-dependent hypertension, and we can really affect their blood pressure by lowering their dry weight.
Mhm.
Patients are reluctant to do that. It causes cramps. It can be uncomfortable for them, especially to push them down to get to that lower dry weight. But if they get through that and get to that lower dry weight, great way to control the blood pressure. And
Yeah.
and honestly, if you get that weight down low enough, if you remove enough of that excess fluid, you can get them off of many of their blood pressure medicines. Hard to do, but that's kind of the promised land.
Okay, so to kind of recap this dialysis stuff, and I think Paul has something to say, is generally tell them not to take their medications on the day, prior to entering the dialysis unit. They could take them later in the day when their blood pressure comes back up or on non-dialysis days. And the meds we're using are pretty similar to what we would use in patients who aren't on dialysis. So calcium channel blockers, ACE-ARB, beta blocker, you said even spironolactone in select patients.
Yeah, and I want to emphasize some patients have no trouble with hypotension during dialysis. Those patients, it's fine for them to take the blood pressure before. The stem here we had word that the patient was having some hypotension on dialysis, and those are the patients you want to be careful about. But if they're not having trouble with hypotension, go ahead and just let it rip and take the medicines before.
Yeah, and nothing earth shattering to add, but and we've made this point, I think, on prior episodes, but this is the patient where I would actually call and talk to the patient's nephrologist if at all possible. And in all the systems I worked at, dialysis visits are largely a black box. I may get some sort of report that is sort of unintelligible, but like you don't know what conversations were had about the medications. It just becomes very complicated. You can be fighting unnecessarily if you don't coordinate things well. So I think it's helpful to know your thought process, but I think for circumstances like this, I'm always talking to the patient nephrologist if I can do it, because I'm hesitant to make medication adjustments on my own because I just don't know what's happening that half of the week that I'm not seeing the patient.
Okay. Well, the other thing I wanted to ask about is, I guess, just real quickly, midodrine, Joel. I've seen patients like getting that medicine. Am I just seeing that because these are sick, hospitalized patients that are sort of coming near the end and they're needing that just to make it through dialysis, or is that in a dialysis unit? Is that a common practice?
So yes, for both those things. Like it is a terrible prognostic sign. If you look at the outcomes of dialysis patients that are requiring midodrine to get through dialysis, it's bad. These are usually end-stage heart failure patients, and they're not doing well. It's not great. But then again, they still need to get dialysis. We need to help our nurses to allow these patients to get through their dialysis. We need to get that fluid off. If we can't get the fluid off, we're going to be in a death spiral of increasing fluid gains. And so we're using a lot of, we do use midodrine in those situations, but it's not a great situation to be in. Patients are doing poorly.
Well, I think the last thing we wanted to touch on is when he was still CKD4, we talked about, getting the best glucose control we can to try to prevent progression of CKD. Once the patient's on dialysis, does your philosophy about treating diabetes change?
Yeah. I mean, I think you gotta, first thing you gotta look at is, why are we treating the diabetes? We're trying to avoid outcomes and events, and the good glycemic control avoids the microvascular events. And so that's retinopathy and nephropathy and some degrees of neuropathy. And once they're on dialysis, like the big one, you've already missed that. They're on dialysis. You're not going to be able to avoid that going forward. And then the other half of that is the risk. And once you've lost your kidneys, you've lost a significant amount of the gluconeogenesis that your body depends on. And so that, the kidneys are a gluconeogenic organ, so there'll be higher risk of hypoglycemia. And the kidneys metabolize insulin. And so if you're giving patients insulin, that insulin half-life is going to go up. It'll be more effective. And so you got increased risk of treating diabetes with less reward. And I just think it just makes sense to kind of relax our targets. You don't want them to be running really, really high blood sugars, but I don't think you need to be so fastidious about this. You have to relax that a little bit to avoid the complications.
Yeah, Paul, when you get the patient with advancing CKD who comes in celebrating a low A1C, I don't know about you, but I get worried.
My stomach drops. Yeah, that's exactly right.
Yeah.
And they're doing so good on their basal bolus insulin. You're like, we need to reconsider some things. Yeah.
Yeah. All right. Well, Paul, any other questions? We're not going to touch on bone disease in dialysis, patients on dialysis, because that's a black box that I don't think we need to venture into. We thought about it, but we're not going to go into that. So, Paul, anything else you wanted to ask before we go?
No, I mean, I'll ask my usual broad and perhaps unfair question, Joel, because we didn't prep you for this in advance. But I guess, is there anything else that you would want an internist to know about a patient on hemodialysis in order to sort of optimize their care? And I know that that's sort of a broad question, but since we're on the topic of this advanced chronic kidney disease, is there anything that we can do to be helpful and not muddy the waters?
So I guess one of the things that is important to think about is that these patients, they kind of have oftentimes, not all dialysis patients, but, the elderly diabetic patient that's on dialysis, they don't have a long lifespan. They're not going to live a long time. And so
yes,
kind of some of this preventative stuff that we do, focusing, like colonoscopies, like, I'm not sure if preventative measures in this population make sense, right? It's not, they're not like hospice patients, but they don't have a 15-year runway going forward. And so just being thoughtful about what type of medical procedures you're going to introduce to these patients that may not be necessary.
Yeah, that's a great point.
Yeah, I was having the exact same thought as we're discussing the glycemic control, because like the ranges and targets that we talk about are for patients who have fairly long projected lifespans, and not say like 5 years. I know dialysis is something that sort of shortens life, even though it offers a lot of benefit, obviously. So that's very helpful.
Yeah.
Well, Joel, how about some take-home points for the listeners? Just a couple things you want to make sure that they remember from this episode.
Most importantly, when their GFR falls below 30, do not stop their RAS inhibition. ACE inhibition, angiotensin receptor blockers, these are essential treatments for our patients with diabetes, patients with advanced chronic kidney disease. We've got good trial evidence that these patients do well with this. The goal of our treatments is not to preserve GFR. The goal of our treatments is to avoid events like heart attacks, strokes, and dialysis. And that's what we need to be focused on. These drugs do a great job of that. Okay. Secondly, same thing with diuretics. You're going to lose a couple of points of GFR when you get aggressive with the diuretics. That's fine. Everybody does it. It's acceptable. It's what we need to do for our patients. And so go ahead and if you need to use a loop diuretic, which oftentimes happens as their GFR falls below 20, you're going to need to use that to get that fluid off. Go ahead and use your chlorthalidone. And these patients also, these are going to be needed to get good blood pressure control.
All right. Well, that's it. Thank you as always.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, get it? Recaps the latest practice-changing articles, guidelines, and news in internal medicine.
We're committed to high-value, practice-changing knowledge, and we want your feedback, so please email us at askcurbsiders@gmail.com. And it really does help when you subscribe, rate, and review the show on Apple Podcasts, Spotify, or follow us on YouTube. A reminder that this and most episodes are available for CME credit through VCU Health at curbsiders.vcuhealth.org. A special thanks to our writer and producer for this episode, Dr. Fatima Syed, and to our whole Curbsiders team. Our technical production is done by Podpaste. Elizabeth Proto runs our social media. Jen Watto does our Patreon. Krista Chu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, our main Dr. Paul Nelson Williams, thank you and goodbye.